You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is Dr Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 26, 2018. This week, surgical left atrial appendage occlusion, smoking, influenza, stroke care, and unhappy cardiologist. First up is a study on left atrial appendage occlusion via surgery. A stroke is a major complication of AF, and thrombus can form in the left atrial appendage. When patients with AF undergo heart surgery, say for coronary disease or valvular heart disease, some experts feel like it's a good idea to close the appendage while the surgeon is there. A small study with surrogate outcomes presented last year suggested fewer MRI lesions in those who had surgical left atrial appendage occlusion. And recently, a large observational study published in JAMA found that left atrial appendage occlusion at the time of surgery associated with lower rates of readmission for thromboembolism and improved mortality. This sounds good, right? But this study had significant problems. First, it was a non-randomized comparison. Surgeons decided who to close, and researchers compared the results retrospectively. Also, the endpoints were taken from database information rather than being adjudicated like they would be in a trial. Also, anticoagulation status after discharge was unknown to the researchers. The authors noted in the paper in JAMA that RCTs are needed to confirm these findings, but said multiple times during the manuscript that their observations support left atrial appendage occlusion. The senior author of the paper suggested in our news story that a left atrial appendage occlusion during surgery should be the standard of care. I have a column coming up on this paper and the overreaching conclusions of the authors. Here's the bottom line. You can't make the assumption that association is causation in this study or really any observational study. If you are interested in more detail, the one figure in the paper about proves that confounding variables bias the results. Look at the mortality curve in the figure from Jack. The curves separate immediately. So there's no way that left atrial appendage occlusion could deliver that big a difference in the mortality in a matter of months. So it must be that healthier people got left atrial appendage occlusion, and that's why outcomes are better in that group. Overreaching conclusions from observational studies is common. It's up to clinicians to be on the alert for it. This paper is a case study for why we need to read the literature critically. Next topic, smoking. For years, I've counseled patients that smoking even 1 or 2 cigarettes a day ups their cardiac risk significantly. I'm not sure I could have cited them a reference without looking it up. Now I can. In the BMJ recently is a systematic review and meta-analysis of 141 cohort studies. The authors reported relative risks of smoking 1, 5, or 20 cigarettes a day. In men, the relative risk for coronary heart disease events was 1.5 for smoking just 1 cigarette per day, and it was 2.0 for 20 cigarettes per day. Including studies that used adjustment for other CHD risks, the relative risk for smoking were a little bit higher, 1.74 for smoking 1 cigarette per day and 2.27 for 20 cigarettes per day. In women, the relative risks were slightly higher, 2.2 for smoking 1 cigarette per day and 3.9 for 20 cigarettes per day. The relative risk for smoking and stroke were also elevated in the 1 cigarette per day group, albeit the relative risks were slightly lower. This is significant information because many patients reduce but don't eliminate their smoking. Third topic, influenza and myocardial infarction. Here in the southeastern United States, my hospital is overflowing with admission. It is crazy busy. The reason it's influenza is in peak season. An elegant observational study published in New England Journal of Medicine this week details what any hospital-based doctor suspects, that respiratory infections, especially influenza, associate strongly with AMI. Canadian researchers used their health insurance program of Ontario and found a 6-fold increase in AMI incidence in the days after a positive influenza test. The association was gone by day 7 after the positive flu test. This observation, especially with that timing, strongly suggests a potential causation. It's plausible because the widespread inflammation from flu could induce endothelial dysfunction, platelet aggregation, and in general create a favorable milieu for MI. Another finding from the subgroup analysis of this paper was that an increased incidence of MI after flu was observed only among adults greater than age 65 and not in younger adults. The authors advocate wisely, I think, for increased flu vaccine in vulnerable patients with risk factors, things like older age, previous heart disease, and typical CV risk factors. But I think here's the big point. This problem is going to get worse. Our population is aging, and one of the good things about living in this era is that medical technology keeps people living longer. That means there are going to be more people living with diminished organ reserve. Young people mostly do fine with flu, and old people struggle. I'm not sure we have a cure for that, and it's okay. People will never be immortal. Fourth topic today, stroke care. Yet another big interventional stroke trial has delivered impressive results. I offer first-hand testimonials on the coolness of endovascular intervention for stroke. I've seen it in my practice. 1 minute someone is paralyzed or not speaking. After their clot is removed, they're fine, like normal. The big problem here is time. If it's too long, people tend to think the brain is infarcted. But this past November of last year, the DAWN trial found that in selected patients, the window for intervention may be extended to up to 24 hours. And this week, the DIFFUSE 3 trial, an RCT with blinded outcomes assessments of thrombectomy in patients 6 to 16 hours after they were last known to be well, and who had remaining ischemic brain tissue that was not yet infarcted on their scans, this study returned positive results. It was a U.S.-based trial and it was terminated for efficacy. 182 patients were randomized to intervention plus OMT versus OMT alone, OMT being optimal medical therapy. Intervention improved functional recovery and mortality by a lot. Intracranial hemorrhage and adverse events were not increased, and obviously it's best to prevent stroke, but when it occurs, it seems like access to a skilled stroke interventionist, available neuroradiologist, and an on-call team members, much like we have for acute MI, would improve outcomes. Now maybe we need to be training a few more stroke interventionalists. I really love interventional treatments for acute conditions like this. It's pure medicine. It's what we're supposed to do. Treat the sick, not the well. Final topic today is cardiologist burnout. Medscape's annual physician lifestyle report is out, and impressively more than 15,000 doctors from 29 specialties responded. I am shocked to read cardiologists are among the least happiest. Only 40% of cardiologists describe themselves as very or extremely happy outside of work. And only 21%, 1 in 5, describe themselves as very extremely or happy at work. Almost half of cardiologists feel burned out, depressed, or both. I know that electronic health records and the explosion of regulatory nonsense hasn't made life easier for doctors. But still, I love being a doctor and would miss it a lot if I stopped. I hang a lot of my self-esteem on the being a doctor peg. I wonder why cardiologists rank so low. Now, this is just speculation. A colleague of mine suggested to me it might have to do with recent revelations about the marginal nature of what we do outside of the acute setting. I mean, for instance, if PCI and stable coronary disease doesn't improve outcomes, and now may not improve angina over placebo, then why do we search so much for ischemia? And if finding ischemia doesn't improve outcomes all that much, then perhaps that makes cardiologists feel less valuable, because that's what we do. When I was younger, the high-producing cardiologists in our group were either those that read a lot of nuclear stress tests looking for ischemia, or those that did a lot of PCI fixing ischemia, or also those that did ablation and devices. And we were reimbursed handsomely for doing all these procedures. But now reimbursement for the imaging stuff and the doing stuff, the procedures, is down. Perhaps because payers are figuring out that some of the major drivers of cardiologists' big income may not be all that valuable or as valuable as we thought. Of course, listening, examining, synthesizing clinical information. And these things are still crucial, but they pay less well than doing graphics and procedures. Another possible reason we are unhappy is because many, perhaps most cardiologists like being the apex predator of the hospital. In fact, one of the reasons I was drawn to cardiology was because cardiologists seem like the quarterbacks, the captains, the people in charge. Now that we are employed doctors, we're forced to do stupid corporate modules. It's clear that the administrator doctors are now the quarterbacks. Since cardiologists are human, this loss of standing might hurt a bit. To me, though, even if I make less money, I still love electrophysiology and cardiology. After fellowship, I've learned to do CRT on my own. Then I learned AF ablation, and in recent years, I've learned His bundle pacing. I love point-of-care ultrasound, and something as simple as accessing the central veins with ultrasound rather than blindly seems so cool to me. I also like learning how some of the stuff we did in the old days was wrong. I mean, things like putting in pacemakers with atrial fibrillation so we could use high doses of antiarrhythmics. Geez, what were we thinking with that? Remembering the history of our past makes the job more fun, and it's why I'm less confident of promising hyped-up new therapies. Now look, if you have reasons why cardiologists are the least happy, please offer them up in the comments. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. See you again next week. This is Dr Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.